Hello friends, today we'll be demonstrating the dissection of medial sural artery perforator flap. This is a very good flap which can be used both as a free flap and also as a pedicle flap to cover the defects around the knee, upper tibia and sometimes up till the lower one third of the femur. So the marking of the flap starts by making a line that is from the mid popliteal fossa to the medial malleolus. So this line is drawn and 10 centimeter from the midpoint of the popliteal fossa is the usual site where the perforator is identified. So when we are taking it as a free flap, we try to close the donor area primarily so that patient can walk very comfortably very next day. So 6 to 7 centimeter of flap can be closed primarily in a relatively thin adult patient. The surgery is done under tourniquet control and the flap is been harvested from the right leg and the video is made from the right side now. So the perforator is identified. That's a very tiny perforator. So the size of the perforator of medial sural artery flap is usually smaller as compared to those of ALT. Plus, because it's been harvested under tourniquet, it looks more smaller than what actually it is. So if you have any doubt, you can identify the perforator, release the tourniquet. Once you are sure that there are pulsations, then you can go ahead and dissect the flap, the perforator in the muscle as a perforator flap. So you encounter multiple nerve branches which we need to ligate. Once you are sure about the perforator, you extend the incision because as the experience gains, you try to look for more perforator so that you are having a choice to look for, you have a choice to get the best perforator according to the situation. So extend the incision, we found a proximal perforator which we actually did not Doppler, but then we started dissecting it and then we realized this perforator size is better than the one which we have Dopplered and was present proximally distally there, which we have identified in the beginning. Now as I told you, we need try to keep all the options open, so we dissect the flap more proximally, dissect both the proximal and the distal perforator. Distal perforator is the one which we identified before, and then dissect them out. So the more proximal dissection of the pedicle will give you a more pedicle length where you can use it for situations where we can use it for reconstruction of the tongue. So medial sural artery flap is a very good option to replace radial forearm flap, as we don't need very long pedicle in that case and we need a very thin pliable flap which is medial sural artery flap. Now we have dissected, that's the first perforator, the distal one which we identified. There will be plenty of nerve branches. These branches are much more than those for ALT and hence it takes a little more extra time for it, but definitely it gives more pliable or a thinner flap whenever required as compared to ALT. So we dissected out both of these perforators and then furthermore length of the proximal pedicle is done so that we have enough of pedicle for anastomosis in the neck when we are using as a free flap for tongue reconstruction. Basically that's the main indication where we use it nowadays. So these are the two perforators. They have been segregated on the individual rubber loops, some final dissection and then delineation of the veins and the arteries separately so that final pedicle length can be assessed, and depending on that we decide whether we need to take the proximal or the distal perforator. As we could dissect good amount of proximal pedicle, we thought let's take the proximal perforator, which actually we did not Doppler because the size of that pedicle, that perforator is bigger. Although after releasing tourniquet, we could see the pulsation in both the proximal and the distal perforators are good, but the size of the proximal perforator is good, which is entering into the skin as compared to the distal perforator, and the pedicle length is also about 8.5 centimeter, which is more than enough for tongue reconstruction. So we aligned the flap based on the template of the defect, and after the islanding, we that's a perforator being dissected out, and then we decided that this is good length, good pulsation, good bleeding from the skin edge, and then we took the proximal perforator and ligated the distal perforator. Thanks for watching the medial sural artery flap.